students, in this particular session, we are going to discuss number 1, the subepidermal blistering disorders. Now, as we have already studied in module number 1, the subepidermal blistering disorders are broadly categorized into two groups. Number 1, we have the Pemphigoid group, and number 2, Dermatitis herpetiformis. Let us take up the first topic of the Pemphigoid group. Now, in Pemphigoid group, what exactly is the defect here? The defect in the Pemphigoid group lies in the basement membrane zone proteins. It lies in the basement membrane zone proteins. So this is something which all of us should remember. To understand this further, let us again go through the structure of the basement membrane zone. So we have seen it in the module number 1, basics in dermatology. The basement membrane zone is composed of 4 important parts. So the first part is this particular structure, which is called as hemidesmosomes, and this particular structure known as keratin intermediate filaments. So the first zone of the basement membrane zone is hemidesmosomes keratin intermediate filament complex. So this is number 1. Number 2 is the zone below this zone is called as lamina lucida. So lamina lucida is point number 2. Below lamina lucida we have lamina densa, and below lamina densa the area which is referred to as sublamina densa. So these are the 4 important zones of the basement membrane zone. Now let us try to know which are the different antigens which are located in these different zones. Now in the hemidesmosome keratin intermediate filament complex, the 2 important keratin intermediate filaments which we are supposed to remember are keratin 5 and keratin 14. So keratin 5 and keratin 14. Now what are the components of the hemidesmosomes? 2 important components of the hemidesmosomes are BPAG2, BPAG1. So BPAG2, BPAG1, these are the 2 components of the hemidesmosomes. Let's look at the next zone, which is known as lamina lucida. What are the 2 components of lamina lucida? Number 1, we have the BPAG2. Number 2 is laminin. Number 2 is laminin. So what we understand that BPAG2 is a transmembrane molecule. So BPAG2 is expressed both in zone number 1 as well as zone number 2. Now let's go to lamina densa. Now when we are discussing lamina densa, we need to remember here is there is laminin as well as collagen number 4. So laminin as well as collagen number 4. So what we realize here is that laminin is common to both lamina lucida and lamina densa. And finally, in the sublamina densa, what are we going to have? We are going to have collagen 7, which is also referred to as anchoring fibrils. So these were the important components of the 4 zones of the basement membrane zone. So let us now start with the classification of the Pemphigoid group with the different defects. Now out of the antigens which we have just listed a little while earlier, let's take up number 1, BPAG1. Now BPAG stands for Bullous Pemphigoid antigen number 1, and this Bullous Pemphigoid antigen number 1, it has a molecular weight of 230 kilodaltons. And it is involved in which condition? Bullous pemphigoid. This is involved in bullous pemphigoid. Let's take up number 2, BPAG2. Now which are the different diseases which are listed as defects for BPAG2? Number 1, we'll start with bullous pemphigoid. And please remember, dear students, that bullous pemphigoid antigen number 2, its molecular weight is 180 kilodaltons. So 230 kilodaltons is BPAG1, BPAG2 is 180 kilodaltons. So number 1, bullous pemphigoid. Number 2, cicatricial pemphigoid. Number 3, Pemphigoid gestationis. Number 3, Pemphigoid gestationis. And number 4, LABD, which stands for linear IgA bullous dermatosis. Linear IgA bullous dermatosis. So once again, to recapitulate, please remember the 4 important disorders where BPAG2 is the target antigen. Number 1 is bullous pemphigoid. Number 2 is cicatricial pemphigoid. Number 3 is pemphigoid gestationis. And number 4 is LABD, linear IgA bullous dermatosis. And lastly, collagen number 7. Collagen number 7 gets involved in a condition known as EBA, which stands for epidermolysis bullosa acquisita. Epidermolysis bullosa acquisita. Acquisita means acquired. Generally, epidermolysis bullosa, when you listen to this word, you should remember it is genetic, except this condition which says acquisita. This is an acquired form of epidermolysis bullosa. So now let's take up the most important subepidermal blistering disorder, which is called as bullous pemphigoid. So number 1, what is bullous pemphigoid? It is an example for a immunobullous disease. Immunobullous disease. So if you remember, we classified immunobullous diseases based on the level of the split, isn't it? Intraepidermal and subepidermal. What is bullous pemphigoid? D for deep. So please remember, this is characterized by subepidermal split. It is characterized by subepidermal split. So the split is subepidermal. Next, what we need to remember here is, what is the autoantibody which is getting deposited in bullous pemphigoid? The autoantibody here is IgG. The target protein here is hemidesmosomes. And the target antigen over here is BPAG2, BPAG1. So this is 180 kilodaltons and this is 230 kilodaltons. And please remember, when this process is happening, there is no acantholysis. Very, very important. There is no acantholysis which is happening. Acantholysis happens in which diseases? Pemphigus group of disorders. In pemphigoid group of disorders, there is no acantholysis. Now let's go to the disease profile. How will a patient of bullous pemphigoid present? So these patients are usually older individuals, 60 to 80 years of age. And if you look at the sex predilection, it has an equal male is to female ratio. So it's generally equal among men as well as women. And now let's go to the morphology of the lesions. How are the patients going to present? Tense, itchy bullae, which could be on red skin, on erythematous skin, or it could be over the normal skin. So please remember, both presentations are possible. You get tense, itchy bullae. It's an itchy condition. The bullae can be present both on normal skin. It could also be on an erythematous base. Now what is going to happen? Bulla is the primary lesion. So after some time, what is going to happen? This bulla is going to rupture. So usually these bullae in bullous pemphigoid, they are going to rupture usually on scratching, because this is a pruritic condition. And what are you going to get? Once there is a rupture, there is going to be an erosion. And how are these erosions of bullous pemphigoid? Very, very important. They tend to heal. No tendency to extend. Tend to heal. No tendency to extend, which is exactly the opposite in pemphigus vulgaris, wherein acantholysis is happening, the erosions keep on extending, no tendency to heal. Here they tend to heal with no tendency to extend. And what is the distribution of lesions in bullous pemphigoid? You're going to get lesions over the trunk, abdomen, flexural aspects of the extremities. So trunk, abdomen, flexural aspect of the extremities. Now let's go to the different morphologies which I just mentioned to you. So what do we see in the image here? We can see there are tense bullae. There are tense bullae. Few are hemorrhagic in nature. You can see this tense bullae with a shiny surface. It is filled with water. Usually subepidermal blistering disorders will have tense bullae. Here we see some more tense bullae. Here they are distributed on the lower abdomen. I also told you they can be seen on the flexural aspect of the extremities and the thigh as well. Here you can see flexural aspect of the extremities like the thigh, you get these tense bullae in bullous pemphigoid. So please remember that these bullae can be there both on normal skin as well as on erythematous skin. Now let us see what signs we elicit in bullous disorder. Always remember the first sign has to be Nikolsky sign, which I've already explained to you. You have to take a finger and put tangential pressure over the skin. In this condition, Nikolsky sign is going to be negative. Nikolsky sign is positive in pemphigus vulgaris, negative in bullous pemphigoid. Next sign which we elicit here is bulla spread sign. Now bulla spread sign is, what do we do here is, now just imagine this is a tense bulla over here. So this is a tense bulla. So what is going to happen is when you give unidirectional pressure. So what are we doing is we are giving unidirectional pressure from the side. What is going to happen is the fluid will move to the adjacent area. So the margin of the bulla moves to the adjacent area. And if you see this margin, this is called a round regular margin. So when you push from one side, what will happen? The margin of the bulla extends into the adjacent skin, and because it's a tense bulla, when you push, what is going to happen? You're going to round regular margin. So that is why this is the feature which is seen on bulla spread sign. Another variant of this bulla spread sign is the Asbo-Hansen sign. Asbo-Hansen sign. The only difference being in Asbo-Hansen sign, you put pressure from the top. So pressure is applied over the top of the bulla in Asbo-Hansen sign, whereas bulla spread sign is from the side. You give unidirectional pressure. Now let's look at the oral cavity in bullous pemphigoid. 10 to 30% of the patients will have erosions in the oral cavity. Is seen in 10 to 30% of the patient. So we have understood how is the skin presentation, how is the oral lesions. Now let us go to the investigations. The three important investigations we do in any immunobullous disorder. Number 1, we do Zank smear. Number 2, we do histopathology. And number 3, we do direct immunofluorescence. So these are the three important tests that we do. First, let's go to Zank smear. On Zank smear, what is going to happen is we are going to find eosinophils. And please remember this important negative point, no acantholytic cells. No acantholytic cells, only eosinophils will be positive on Zank smear in bullous pemphigoid. Now let's go to the histopathology of bullous pemphigoid. Now here there is a histopathological section of a patient with bullous pemphigoid. First, let's mark the parts. So the first part, what we can see here is, this is the stratum corneum. So this whole thing is the epidermis, the whole thing, and the first layer I've marked is stratum corneum. Now let me mark the stratum basale. Now what do we see here? Now what are we seeing here is this huge bulla here with few cells here, and these few cells are the eosinophils. So very important is just below the epidermis you see a bulla. This is termed as subepidermal bulla. Subepidermal bulla with eosinophils. Subepidermal bulla with eosinophils. So these are some more pictures. So here you can see there are a lot of eosinophils here. Yet another patient of mine who presented with extensive eosinophils. So very important is the infiltrate in bullous pemphigoid is predominated by eosinophils. Next we move on to direct immunofluorescence. On direct immunofluorescence, what is the finding? Now direct immunofluorescence is a test which detects the pathogenic autoantibody. It detects the pathogenic autoantibody using immunofluorescence technique. So using the immunofluorescence technique, we detect the pathogenic autoantibody. So please remember students, as I've already told you, the three questions you need to answer. What is depositing? Where is it depositing? How is it depositing? Now which antibody is depositing in bullous pemphigoid? It is IgG as well as C3. Where is the deposition in bullous pemphigoid? You can see here in the image. This is the basement membrane zone. So please remember, here the deposition happens along the basement membrane zone, and this pattern is referred to as linear pattern. This pattern is referred to as linear pattern. Now let's go on to the treatment of bullous pemphigoid. The treatment is going to be low dose oral steroids. Usually just one immunosuppressive suffices for this condition. It's low dose systemic steroids. Next, let's discuss some special features of the other types of pemphigoid group. Let's take up two important types of pemphigoid. Number one, we'll take up pemphigoid gestationis, and the second one is linear IgA bullous dermatosis. Now, this linear IgA bullous dermatosis, this can be classified based on the age group of presentation. It could be in adults, it could be in children. So what do we call this disease in adults? It's called as LAD, linear IgA disease in adults. Whereas in children, there's a very special name for this condition. It's called as CBDC, which stands for chronic bullous dermatosis of childhood. Chronic bullous dermatosis of childhood. This is termed as CBDC. Let's take up the first topic, pemphigoid gestationis. Now, pemphigoid gestationis is also referred to as herpes gestationis. Also referred to as herpes gestationis. Now, what is this disease basically? This disease is pemphigoid in pregnancy. Bullous pemphigoid in pregnancy. So this disease is bullous pemphigoid in pregnancy. Then why it's called as herpes gestationis? Dear students, please remember this is a misnomer. Okay. Herpes gestationis has nothing to do with herpes infection. So it's a misnomer that this condition is called as herpes gestationis. What is this disease? It is bullous pemphigoid in pregnancy. The target antigen over here is BPAG2. That's bullous pemphigoid antigen number 2. Now let's see the morphology of the lesions. What kind of lesions do we get in pemphigoid gestationis? We get urticarial plaques. And tense bullae. Urticarial plaques and tense bullae. If we were to look at the distribution, the first important site where you get the lesions is periumbilical. So periumbilical is the initial site. Where we get lesions in pemphigoid gestationis, and then it also extends to involve the thighs and the abdomen. So abdomen and thighs are the other areas where we can have lesions. And what is the treatment for this condition? The treatment for this condition is systemic steroids. Systemic steroids. So what do we see in this image here is the presence of this urticarial plaques. As I told you, the initial site is periumbilical. So this is how it's going to start. Then it involves the abdomen, and then it's going to involve the thighs. You can have urticarial plaques as you see in the image. You can also have tense bullae. Now we move on to chronic bullous disease of childhood, that is CBDC. The first point what we need to remember here is which is the autoantibody here? It is IgA. And which age group does it present in? This is going to present in the childhood age group. And why this question is repeatedly asked in the exam is because of the arrangement of lesions. So what happens in CBDC is you get annular arrangement of vesicles. Annular arrangement of vesicles. So here if we have to remember, this is going to be the arrangement, annular arrangement of vesicles, and this has a characteristic name. This is also known as cluster of jewel or string of pearl appearance. So please remember, dear students, that you get annular arrangement of vesicles. This is compared to cluster of jewel or string of pearls kind of appearance, and the distribution is generally perioral and perineum. So perioral and perineum are the most common sites where you get lesions of this CBDC. So this is an image where you can see annular arrangement of vesicles. So this is the annular arrangement of vesicles. This is called as cluster of jewel or string of pearls appearance. Very characteristic of this condition. What is the treatment for this condition? The treatment for this condition is a drug called dapsone. This is the drug of choice. Now, dapsone is the drug of choice for this condition because in CBDC, the most important infiltrate is neutrophil, and dapsone inhibits neutrophil chemotaxis. It inhibits neutrophil chemotaxis. That is why it is a drug of choice in CBDC, because neutrophil is the most important cell in chronic bullous disease of childhood.